Hi, I am Ms. Palak Parik, Assistant Professor, Department of Pharmaceutical Chemistry, Institute of Pharmacy, Nirma University, Ahmedabad, with interesting and learning episode of B.Pharma on the important unit of general anesthetic agents, which are the very important units of the section of Medicinal Chemistry 2, 6th semester, which is prepared by me and Professor Manjunath Ghate, Professor and Head, Department of Pharmaceutical Chemistry, Institute of Pharmacy, Nirma University, Ahmedabad. Now let's start our episode while taking a look at what we are going to learn today. There are 5 modules. Module 1 is about Introduction to General Anesthetic Agents. Module 2 is about Classification of General Anesthetic Agents and their ideal properties. Next, Module 3 is about Mode of Action of General Anesthetic Agents. Module 4 is about Gases and Volatile Liquid Anesthetics. And last, Module 5 is about Intravenous Anesthetic Agents. Let's start with Introduction about General Anesthetic Agents. Module 1, in which first definition is what is General Anesthetic Agents. General anesthetics are a group of drugs which produce reversible loss of all sensations and consciousness. The absolute loss of sensation is termed as anesthesia, which is derived from the Greek word which means insensitivity or lack of feeling. General anesthetics bring about descending depression of the central nervous system, starting with the cerebral cortex, the basal ganglia, the cerebellum and finally the spinal cord. These drugs are used in surgical operations to induce unconsciousness and therefore abolish the sensation of pain. Now let's see the history of general anesthetic agents. Horace Wells, a Hartford dentist, first and foremost demonstrated the uses of nitrous oxide, which is also known as laughing gas, as an effective surgical anesthetic in 1844 for tooth extraction. However, its application as a general anesthetic resurfaced in mid-1860s when it was dispensed in steel containers as an admixture with oxygen. Interestingly, nitrous oxide finds its application even today, particularly in combination with other anesthetics as well as analgesic agents. Later on in 1846, a Boston dentist, William Morton, demonstrated the use of ether as a general anesthetic in a public demonstration at the Massachusetts General Hospital. In actual practice, the uses of diethyl ether followed by cyclopropane were withdrawn completely for being highly toxic, amalgamated with equally dangerous physical properties such as flammability and explosiveness. The first intravenous anesthetic, that is thiopental, was introduced in 1935. That is about the brief history of general anesthetic agents. Now moving toward our next topic, that is stages of anesthesia. The ideal general anesthetic state is characterized by a loss of sensations and includes analgesia and muscle relaxation. Neuronal depression in specific area of the central nervous system is believed to be largely responsible for such an anesthetic state. The areas involved include many cortical regions that are represented by excitatory pyramidal cells, inhibitory or excitatory stellate cells. Now we will briefly see various stages of anesthesia, stage 1 to stage 4. Stage 1 is known as analgesia, that lasts from onset of drowsiness to loss of eyelash reflexes, that is blinking when eyelash is stroked. Variable levels of amnesia and analgesia are seen in this stage. The patient is considered unconscious at the end of stage 1. The stage 1 is characterized by a mild depression of higher cortical neurons, and this stage is suitable for minor surgical procedures that do not require significant neuromuscular relaxation. Now moving to our next stage, that is known as excitement or delirium. This stage begins with the loss of consciousness, and the stage of excitement is characterized by agitation and delirium. During this stage, salivation may be copious, heart rate and respiration may be irregular. Induction agents are designed to move the patients through this undesirable stage quickly. Now moving to the main stage, that is known as surgical anesthesia, stage 3. This stage is divided into 4 planes characterized by increasing CNS depression. First, loss of spinal cord reflexes. Second one is decreased skeletal muscle reflexes. Third one is paralysis of intercostal muscles. And fourth one, that is last, loss of most of the muscle tone. Stage 3 is also characterized by irregular breathing, a loss of many reflexes and roving eyeball movements. Last stage of the anesthesia is about medullary paralysis. It is also known as respiratory paralysis state. Respiratory or circulatory failures occurs at depression of vital centers of medulla and brain stem occurs. Now the ideal anesthetic combination will allow the patient to proceed quickly from stage 1 to stage 3 and avoid stage 4. Inhaled anesthetics are used in combination with other drugs to induce anesthesia. That is about what is general anesthetic agents and stages of anesthesia. Now beginning with the module 2, that is about classification of general anesthetic agents and their ideal properties. Let's begin with the classification of general anesthetic agents. They are mainly divided into 2 categories. First one is known as inhalation anesthetic agents and second one is known as intravenous general anesthetic agents. Inhalation general anesthetic agents are further classified into 2 categories, gases and liquids. Gases includes cyclopropane and nitrous oxide, and liquid inhalation general anesthetic agents includes halothane, desflurane, enflurane and other halogenated hydrocarbons as well as chloroform, ethyl chloride and vinyl ether. Next is second category, that is known as intravenous general anesthetic agents. They are further divided into 4 subcategories. The first category is ultra short acting barbiturates. Examples belonging to this category include thiopenton, thioamylal and methoxetal. Second category is aryl cyclohexylamine derivative. Example is ketamine. Third category of intravenous general anesthetic agents include benzodiazepine derivatives. Examples are midazolam and diazepam, and last one is miscellaneous agents which include etomidate and propofol. Now moving towards the subpart of second module, that is about characteristics of the ideal general anesthetic agents. Characteristics of ideal general anesthetic agents are listed below, but unfortunately the agent that fulfills all these characteristics is currently unknown. The first and foremost important ideal characteristic include rapid and pleasant induction of surgical anesthesia as well as rapid and pleasant withdrawal from surgical anesthesia. It should possess adequate relaxation of skeletal muscle. It must be potent enough to permit adequate oxygen supply in mixture as well as with wide margin of safety, and it must be non-toxic to human body. It must have minimum solubility in blood and tissues, and it must be stable on the shelf and during the administration. There should be absence of adverse effects like cardiotoxicity, hepatotoxicity, renal toxicity and neurotoxicity. General characteristics of inhalation anesthetic agents include it must be non-inflammable as well as non-explosive. It should be chemical compatible with anesthetic devices. It must be non-reactive as well as inexpensive. That is all about the ideal characteristic of general anesthetic agents. Module 3 is about mode of action of general anesthetic agents. The mechanism of action of the inhaled anesthetics is not exactly known. Unlike most drugs, inhalation anesthetics, which include substances as diverse as halothane, nitrous oxide and xenon, belong to non-recognizable chemical class. The shape and electronic configuration of the molecule is relatively unimportant, and the pharmacological action seems to require only that the molecule has certain physicochemical properties. Early theories, particularly the lipid theory, were therefore based on rather general physicochemical ideas. Because we now know much more about functional components of cell membranes, the principal structures affected by anesthetic drugs, the emphasis has shifted towards identifying specific protein targets. Some of the theories of anesthetic action are covered below. The first theory is Mayer-Overton theory, also known as lipid theory. In the early 90s, Hans Mayer and Charles Overton suggested that the potency of a substance as an anesthetic was directly related to its lipid solubility or oil-gas partition coefficient and their anesthetic property known as minimal alveolar concentration, that is MAC. The minimum alveolar concentration is defined as the concentration at 1 atmosphere of anesthetic in the alveoli that is required to produce immobility in 50% of adult patients subjected to a standard surgical incision. Compound with high lipid solubility required lower concentration to produce anesthesia. Minimum alveolar concentration, that is MAC, of a number of general anesthetics shows excellent correlation with their oil-gas partition coefficient. The Mayer-Overton studies did not suggest any particular mechanism but revealed an impressive correlation for which any theory of anesthesia needs to account. Oil-gas partition was assumed to predict partition into the membrane lipids, consistent with the suggestion that anesthesia results from an alteration of membrane functions. How this simple introduction of inert foreign molecules into the lipid bilayer could cause a functional disturbance is not explained by the lipid theory. Two possible mechanisms, namely volume expansion and increased membrane fluidity, have been suggested and tested experimentally, but both are now largely discredited and attention has swung from lipid to proteins. The correlation of potency with lipid solubility being explained by the effect of lipid solubility on the concentration of anesthetic adjacent to its supposed protein target in the hydrophobic region of the neuronal cell membranes. Interaction with ion channels. Following early studies that showed that anesthetics can bind to various proteins as well as lipids, it was found that anesthetics affect many ligand-gated ion channels and many anesthetic agents are able at concentrations reached during the anesthesia to inhibit the function of excitatory receptors such as ionotropic glutamate, acetylcholine or 5-hydroxytryptamine receptors, as well as enhancing the functions of inhibitory receptors such as GABA-A, that is known as gamma aminobutyric acid and glycine. The GABA-A receptor is the sole target for benzodiazepines and also appears to be a major agent for intravenous anesthetics such as thiopental, propofol and etomidate that act at a site on the receptor different from the benzodiazepine binding site. The most studied receptor that inhaled anesthetics act on is GABA-A receptor. Inhaled anesthetics enhance chloride ion conductance into the cell and thus hyperpolarize the cell membrane and prevent impulse transmission. They act at GABA-A receptor in a manner similar to the benzodiazepines but not identical. The binding site is postulated to be between the second and third transmembrane segment of the GABA-A alpha-1 receptor subunits. Molecular modeling studies based on mutagenesis data and structurally homologous proteins predict the existence of an inhaled anesthetic binding site on GABA-A receptor. The 2-pore domain potassium channel known as TREK is another specifically anesthetic sensitive channel which is activated and thus reducing membrane excitability by low concentration of volatile anesthetics. Inhaled anesthetics are also proposed to inhibit the excitatory synaptic channel activity of neuronal nicotinic acetylcholine receptors, glutamate receptors which include NMDA and AMPA, sodium channels, potassium channels, calcium channels. They all are voltage gated, cardiac and neuronal, and ryanodine receptors. The multitude of receptor channels that are affected to various degree by specific inhaled anesthetics leads to the current theory that multiple receptors are targets of the volatile anesthetics and no single receptor drug interaction can fully explain their mechanism of action. In summary, general anesthetics inhibit excitatory channels, especially glutamate receptors, and facilitate inhibitory channels, particularly GABA A, but also glycine and certain potassium channel. And these interactions are targeted at specific hydrophobic domains of the channel proteins. Dear friends, up till now you have gained a complete idea about basics of general anesthetic agents with their mechanism of action and classification. If you have missed any of our module or content, you may log on to our website www.cec.nic.in to download videos, FAQs, LOR and other contents so that you can remain updated with this chapter. Now, let's move ahead to our next module, that is about inhalation anesthetics and intravenous anesthetic agents. Next is module 4, that is about detailed studies on gaseous and volatile liquid anesthetic agents. The inhalation anesthetics in use today are nitrous oxide, halothane, isoflurane, desflurane and sevoflurane. The chemical structures for these compounds and some of historical interest are reported in figure. They are mainly categorized into two categories. First category is gaseous inhalation anesthetic agents. Examples are cyclopropane and nitrous oxide, and second subcategory is liquid inhalation anesthetic agents. Examples are halothane, desflurane, enflurane, isoflurane, methoxyflurane, sevoflurane and chloroform, as well as vinyl ether and ethyl chloride. Next is about structure activity relationship of the volatile general anesthetic agents. The chemical structures for the inhalation anesthetic agents can be seen in the figure. While it is true that there is no single pharmacophore for the inhalation anesthetic agents, the chemical structure is related to the activity of the drug molecules. The first subcategory is about SAR of alkanes and cycloalkanes. The first SAR studies conducted independently by Mayer and Overton in 80s showed a distinct positive correlation between anesthetic potency and solubility in olive oil. Many series of compounds confirm this simple relationship, but exceptions to the model exist. The potency of alkanes, cycloalkanes and aromatic hydrocarbons increases in direct proportion to the number of carbon atoms in the structure up to a cutoff point. Cutoff point is the small n in the figure. Within the N-alkane series, the cutoff number is 10 with N-decane showing minimal anesthetic potency. In the cycloalkane series, the cutoff number, that is small n in the figure, in the most studies is the 8 with cyclooctane showing no anesthetic activity in red. The reduced activity of the compounds beyond their cutoff numbers could be a result of problems getting to the site of action or inability to bind to the site of action and induce the conformational changes required for anesthetic activity. The cycloalkanes are more potent anesthetic than the straight chain analogues with the same number of carbons. For example, the minimum alveolar concentration of cyclopropane in rats is about 1/5 of the minimum alveolar concentration of N-propane. Next is about the SAR of alkanol series. A similar increase in the potency with increase in carbon length was seen in the N-alkanol series. In addition, the N-alkanol with a given number of carbons is more potent than the N-alkane with the same chain length. Next in SAR is about effect of halogenation. The first inhaled anesthetics used in the late 80s, that is diethyl ether and cyclopropane, caused laryngospasms. These compounds were also explosive and flammable, require careful handling. Early studies found that halogenating the ethers decreased the flammability of the compounds, enhanced their stability and increased their potency. Higher atomic mass halogens increased potency compared to lower atomic mass halogens. For example, as we can see in the figure, replacement of fluorine in desflurane with a chlorine atom to form isoflurane increased potency more than 4-fold. In general, halogenated ether compounds are caused less laryngospasms than non-halogenated compounds. Unfortunately, halogenation also increased the propensity of the drugs to cause cardiac arrhythmias and/or convulsions. Halogenated methyl ethyl ethers were found to be more stable and potent than halogenated diethyl ethers. The commonly used inhaled anesthetics are ethers or aliphatic hydrocarbons with 2 to 5 carbon atoms in their structures. The effect of halogenating the alkanes, cycloalkane and alkanol compounds has been extensively studied in the animal models. For the normal alkane series, fully saturating the alkane with fluorine abolished the activity except when N is equal to 1. When N was 2 to 4 carbons, the highest potency was seen when the terminal carbon contained 1 hydrogen. When N was greater than 5 carbons, the potency decreased in this series. The potency of the dihydrogen compounds was greater than the equivalent non-fluorinated alkane compounds. Similar findings for the normal alkanol series were found. The most potent fluorinated normal alkanol were the CHF2, CF2 and CH2OH series, where N was between 2 to 5, that is number of carbon atoms. The decrease in activity for the completely fluorinated compounds would not be predicted by the Mayer-Overton hypothesis. Next, we will discuss about synthesis of various inhalation anesthetic agents. First, we will start with cyclopropane. Cyclopropane may be prepared by the action of zinc metal or sodium metal or magnesium metal on 1,3-dichloropropane. Cyclopropane is one of the most potent general anesthetic agent. The chief merits of this anesthetic over others are due to its non-irritant nature and rapid recovery from anesthesia. Its demerits include depressant effects on respiration, tendency to induce cardiac arrhythmias and to enhance hemorrhage. Next synthesis is of ethyl chloride. Ethyl chloride can be prepared by the action of zinc chloride on alcohol. Ethyl chloride is used in the past as a general anesthetic by inhalation, particularly for minor operations. It is also employed as local anesthetic by freezing. It is no longer used as a general anesthetic agent because of its damage to the liver and serious disturbances of the cardiac rhythm. Third synthesis of inhalation general anesthetic agent is divinyl ether. It is prepared by treating ethylene chlorhydrin with sulfuric acid to obtain intermediate 1, that is 2,2-dichloroethyl ether, which on subsequent treatment with alkaline ethanol yields vinyl ether. A volatile anesthetic administered by inhalation, it is 4 times as potent as ether. Its prolonged inhalation for longer operations is rather harmful because of the risk of liver necrosis. Next is about toxicities associated with halogenated general anesthetics. Although few signs of toxicity usually are observed during the short-term, infrequent administration of general anesthetics, a few well-defined toxic effects have been noted. For instance, halothane and methoxyfluorine are known to produce hepatotoxicity and nephrotoxicity respectively. Both of these toxic reactions are believed to result from highly reactive metabolites of the parent compounds. Except for ether, which is not hepatotoxic, all halogenated liquid anesthetics are capable of producing liver damage. This is all about classification, structural activity relationship studies as well as synthesis of selected inhalation general anesthetic agents. The last module is about intravenous anesthetic agent, that is module 5. Intravenous anesthetics usually cause unconsciousness when administered parenterally. However, the duration of action can be safely monitored depending on the amount of drug administered. They are further divided into 4 categories. The first category is about ultra short acting barbiturates. Examples are thiopenton, thioamylyl and methohexital. Ester undergo heterocyclization with thiourea using sodium ethoxide as a base to produce thiopentyl sodium. The next category belonging to intravenous anesthetic agents is aryl cyclohexylamine derivative. The drug is ketamine. Ketamine is a rapid acting agent that can be used for introduction, used as the sole agent for general anesthesia or combined with other agents. Unlike the proposed mechanism of action for the most anesthetics, ketamine does not act at the gamma aminobutyric acid A, that is GABA A receptor. Ketamine acts as a non-competitive antagonist at the glutamate NMDA receptor, a non-specific ion channel receptor. It is an intravenous anesthetic agent of choice for surgical operations of shorter duration, but with additional doses, it may effect anesthesia for a span of 6 hours or even longer. Next is synthesis of ketamine. Ketamine, chemically known as 2-orthochlorophenyl 2-methylamino cyclohexanone, is synthesized from 2-chlorobenzonitrile, which reacts with cyclopentyl magnesium bromide to give intermediate one, that is known as 1,2-chlorobenzoyl cyclopentane. The next step is bromination using bromine to the corresponding bromoketone, which upon interaction with an aqueous solution of methylamine forms the methylamino derivative. During this reaction, a simultaneous hydrolysis of the tertiary bromine atom occurs. On further heating, the reaction product in decalin, a ring expansion rearrangement occurs, causing formation of ketamine. The third subclass of intravenous general anesthetic agent is benzodiazepines. The drug belonging to this category, which can be used as general anesthetic agents, are midazolam and diazepam. Benzodiazepines have been used adjunctively. Intravenous general anesthetic agent is miscellaneous. Drugs belonging to this category include etomidate and propofol. Propofol is an injectable sedative hypnotic used for the induction and maintenance of anesthesia or sedation. Although unrelated chemically to the inhaled anesthetics, propofol has been shown to be a positive modulator of the GABA A receptor, also known as gamma aminobutyric acid A receptor. The binding site on GABA A is distinct from the benzodiazepine binding site. Etomidate is a carboxylated imidazole intended for the induction of general anesthesia. It is marketed as the more potent R-levoisomer, and it is believed to exert its anesthetic effect via positive modulation of GABA A receptor. With this, we have completed all the 5 modules of general anesthetic agents. Now last is the conclusion about general anesthetic agents. With all this information, here we comes to the end of today's lecture. General anesthetics are a structurally diverse class of medications that enable clinicians to execute surgery and other noxious procedures. Understanding about different stages of anesthesia as well as the medicinal chemistry aspects of various anesthetic agents helps to optimize therapy to meet patient specific needs. Do keep in mind what we discussed today. Time for your self-study. This is Miss Palak signing off. I'll be back with one more lecture in this series, that is about psychopharmacological agent 1. If you want to learn more and enhance your knowledge, you may log on to our website for MCQ, quiz, LORs on www.cec.nic.in. Till then, keep studying. Goodbye.